My name is Vera Cappelletti. I'm a senior investigator from the National Cancer Institute in Milano. And I'm working here in a laboratory together with a few collaborators and with a strict interaction with our clinicians in the hospital. Today, I'm going to present you some data from a poster dealing with feasibility of liquid biopsy in patients with biliary tract cancer. As you can see from my poster, in patients diagnosed with advanced biliary tract cancer, the limited access to tissue samples restrains very much the clinical applicability of new molecular findings. So, as in other tumors, liquid biopsy could represent a possible solution for overcoming this tissue restraints of inavailability. However, it has been very poorly explored in patients with biliary tract cancer patients. Here, we are focusing on the detection of CTC by exploiting a new unbiased enrichment strategy and detection strategy for CTC, which has been developed in our laboratory and which allows us to identify new subpopulations of CTC lacking the classical epithelial markers. And this leads to the identification of high percentage of patients which rate as positive for CTCs. Meanwhile, we are also exploring the feasibility of ctDNA analysis, both by tracing with droplet digital PCR mutations which were detected in the tissue when the tissue was available, or which were identified by exploiting target next generation sequencing on cell-free plasmatic DNA and were then validated by droplet digital PCR. We used longitudinally collected samples from 27 patients to separately test the feasibilities of CTC and of ctDNA detection on distinct blood samples collected at the same time. All patients have signed a consent form to donate blood for research purposes. Prior to treatment start, at least one CTC per 10 ml of whole blood was detected in 61% of samples, and fluctuations in the CTC number were observed in samples collected during treatment. ctDNA was instead detectable at baseline in 41% of samples. I will next describe 6 exemplary patients monitored over few treatment lines. BT10 is a patient with intrahepatic cholangiocarcinoma. The disease was monitored tracing only the FGF receptor mutation identified in the tissue, since when we attempted a direct sequencing of plasma DNA, we didn't reveal any new additional mutation. Similarly to CTC, which are represented by the orange line, the FGF receptor mutation, which is represented by the red line, was informative both in the second line treatment with derazantinib and in the third line treatment with FOLFIRI, and perfectly mirrored imaging-based treatment response with an increase before death. At this time, in the last point, no mutations were detected when we repeated the direct sequencing of plasmatic DNA. Now I want to draw your attention to patient BT24. This is a 30 years old patient which presented to us with a 5 centimeter mass between the pancreatic head and the duodenum, which at the endoscopic biopsy revealed an extrahepatic cholangiocarcinoma with a KRAS G13D mutation. Due to unresectable disease, treatment with cisplatin and gemcitabine was started. At the time, the patient was negative for the G13 KRAS mutation in the plasma, as you can see from the blue line in the first left part of the graph. At a new imaging, confirmed progression, however, treatment with atezolizumab was started, and concomitantly a rise in ctDNA levels were observed. Immunotherapy was stopped after an initial response due to the appearance of a liver progression. At that time, 6 CTC were detected and plasma sequencing revealed a new KRAS mutation and a mutation at CTNNB1 beta-catenin. These two mutations are respectively shown in red and green. A third line was started with FOLFOX, but was interrupted due to poor tolerability by the patient, and a third surgery attempt was tried, and with a short response until appearance of a retroperitoneal node and a testicular metastasis, which again was treated with surgery. But at this time, plasma analysis revealed a strong rise in the CTNNB1 mutation, beta-catenin, depicted in green, and also a new TP53 mutation appeared. Well, patient BT19, this is a gallbladder patient, and in this patient, no tissue sample was available for mutation analysis. And when we collected plasma for attempting mutation analysis on ctDNA, we didn't find any single mutation. However, CTC were informative and mirrored the treatment response as evaluated by imaging. In BT49 patient, this is an intrahepatic cholangiocarcinoma patient, and again, no mutations were detected in the tissue. The tissue was available this time, and no mutation were detected in the plasma as well. But CTC fluctuations mirrored and were consistent with the clinical treatment response, except for the sample at the end of treatment after the first line, which is platinum and gemcitabine. Okay, B47 patient is a gallbladder patient again with a TP53 mutation detected at tissue level and traced in the plasma by droplet digital PCR. The variant allelic frequency that you can observe in the red line still maintains around 10%, indicating an absence of response. And in fact, it was consistent with the failure to respond to the treatment, whereas CTC fluctuations were not consistent with the treatment response at all times. Similarly, in BT54 patient, again an intrahepatic cholangiocarcinoma, first-line treatment achieved disease stabilization and CTC drop, but the stable presence of the IDH2 mutation in plasma and its increase, a very strong increase during the second part of the treatment, was consistent with the recorded progression. Well, so from this data, we can conclude that liquid biopsy approaches are definitely feasible in biliary tract cancer patients, both for CTC and for ctDNA. Moreover, thanks to the identification of non-conventional CTCs, CTCs which lack classical epithelial markers, much more CTCs are detectable during treatment and can be associated with treatment response. Still, CTC detection remains very challenging from a technical point of view and presents therefore technical difficulties and limitations. On the other side, ctDNA monitoring represents a promising approach worth to be further explored in the context of clinical studies in homogeneously treated patients. Cell-free DNA sequencing by target next-generation panels not always allows detection of mutation, maybe due to limitation of the actually available panels. And it's important that the validation of mutation by droplet digital PCR is always recommended. I would like finally to thank all my collaborators, all the clinicians at the hospital, and a big thank you also to all patients who consent to donate their blood for these research purposes. Thank you very much.